Exploring prepartum and postpartum depression. Historical overview. According to the World Health Organization, an estimated 3.8% of the world experiences depression. Prepartum or perinatal depression is a serious mood disorder that affects women during pregnancy and may go past 1 year after childbirth or even longer. This type of depression typically affects up to 1 in 5 new moms and 1 in 10 new dads. Women who have experienced depression during a previous pregnancy have higher chances of dealing with depression again in other pregnancies to follow. Having certain personality traits and a history of mental health issues prior to pregnancy increases the chances of depression pre- and postpartum. While it is known that women face depression during pregnancy, more attention is typically focused on postpartum depression symptoms. Why the perinatal phase is crucial. The perinatal phase is important because it constitutes a sensitive period during pregnancy, as well as the afterbirth period, where the organs of the newborn are in their prime developmental stages. The experiences and situations that a mother goes through during pregnancy can have long-lasting impacts on the newborn baby. Overall, the physical and cognitive state of the mother during and after pregnancy sets the stage of a child's future. Factors that increase risk of developing pre- and postpartum depression. Lack of social support is among one of the top reasons why women begin to feel depressed during pregnancy and thereafter. For women of color, barriers like mode of transportation to appointments, ability to afford childcare, limited health insurance, and overall healthcare mistrust create stress, causing depression. Women of lower socioeconomic status and women of color tend to experience depression at higher rates than their more affluent white counterparts. Disparities faced by marginalized pregnant women dealing with depression. Within the African American and Latino communities, women statistically show more symptoms of depression than their non-Latino white counterparts. These two groups often deal with lack of social support due to racial stigma and racism within the maternity care system for medical personnel. Black and Latino women who are international natives deal with separation from extended families and lack of familiarity with medical systems in the country they have immigrated to. Symptoms of pre- and postpartum depression. Common symptoms include strong mood swings, crying excessively, insomnia, excessive fatigue, anxiety attacks, hopelessness, and feelings of worthlessness, shame, guilt, and inadequacy. Pre- and postpartum symptoms of depression last longer, are more severe than baby blues, and usually require help to mitigate. Treatments in the U.S. and other countries. In the United States, treatments usually include psychotherapy, which is a goal-oriented therapy practice that helps a person shift their thinking pattern and better manage emotions on their own, and antidepressants. Cognitive behavioral therapy, or CBT, is another utilized practice in the U.S. because it has led to improvements in postpartum depression and perceived social support. In Japan, complementary and traditional medicines like the use of herbal supplements, shiatsu, and acupuncture are utilized. A strong support system is also vital for women dealing with symptoms in order to have a more successful chance at recovery, no matter where they are in the world. Proposed plan of action. The Social Justice Action Plan that will be proposed and conducted to address depression experienced among pregnant women will consist of a variety of educational-based forums. They will inform expecting mothers and those that make up their support systems, spouses, family members, and friends, of the seriousness of perinatal depression and how to access and use resources. It will consist of stages that inform mothers and their support system on how to act depending on what the expected mother is experiencing. Services will be held and offered on a continuous basis through multiple encounters so that expecting mothers and their extended counterparts have multiple opportunities to become informed and act accordingly. Locations where intervention services will be held and accessible will include doctors' offices, primary care physicians and gynecologists' offices, websites, social media, and phone hotlines. Organizations to collaborate with. Collaboration with the Maternal Mental Health Leadership Alliance would be ideal because they provide resources for women in marginalized communities such as Black, Indigenous, persons of color, women, mothers, and birthing people. The National Maternal Mental Health Hotline is another organization that would be ideal to collaborate with. It is a free and 24/7 and gives support to women and new moms. Partnership with this organization will help with phone operation and services and a social action plan. With the hotline, having operators who have had similar experiences or are part of a support circle themselves will be great candidates so that pregnant women seeking help feel seen and understood. Collaboration with the Mayo Clinic, who is widely known to be the best in an array of areas, including gynecology, will be useful in order to stay abreast with the latest news and trends so that the best services continue to be offered. The American Pregnancy Association and the Postpartum Support International are also entities worth partnering with because they specialize in depression and emotional changes experienced during pregnancy. Stakeholders. In order to fund and allocate necessary resources for educational-based interventions, stakeholders should consist of those who will be supporting services and those utilizing services. Pregnant women themselves, along with their families, can serve as stakeholders by providing word-of-mouth advertisement about knowledge they find out about through educational-based interventions. Other stakeholders would consist of those with whom partnerships have been established for collaboration on interventions. Local governmental agencies could also pose as potential stakeholders once they have been presented with facts on the importance of the social justice action and themselves feel inclined to participate and support. Potential barriers and challenges to this proposed plan of action. Some collaborators may be hesitant to participate because they feel an education-based route is not enough. Barriers to funding for resources may arise from the need to print copious amounts of pamphlets and informational how-to guides, and those providing funds may want to see a particular improved statistic in order to continue giving funds. Another barrier can arise from the spouses and family members of pregnant women who lack clarity in their role and responsibilities as a support system. Individual level factors like perception, traditions, and beliefs that those individuals operate by in their everyday lifestyles can pose as a barrier because all of the up-to-date information can be provided. However, if the person is not open or receptive to the information, it is useless and will not be as effective as intended. Why this plan of action was chosen. Rationale for choosing this plan of action stems from the lack of studies and treatment available that focus solely on prepartum or perinatal depression. Through extensive literature review, the same sentiment was expressed, that focus on studies to learn more about perinatal depression are very few. Tending to the needs of a woman dealing with perinatal depression are vital for an overall healthy operating family unit in the development of children. An educational-based intervention to address perinatal depression in pregnant women is an important need that should be taken seriously, not only by expecting mothers themselves, but by healthcare practitioners and the present support system in the lives of those expecting mothers.